Prevent contamination of a clean area with a soiled pad. Repeat the same cleansing procedure under the neck plate, on the skin of the client. Be sure to use cotton applicators to dry the skin under the neck plate to prevent skin irritation or breakdown. If the tracheostomy tube has an inner cannula, then the sterile cleaning of it can begin now. Remove the inner cannula from the outer cannula and place it in solution of hydrogen peroxide and sterile saline to soak. Nurses differ on whether they do this before or after the cleaning of the neck plate. The soak should not take but a few seconds, so either timing is good for the client. Take off the non-sterile gloves and wash hands, then place on sterile gloves so that the inner cannula can be cleaned. Using the tiny wire brush provided, scrub the inside and outside of the soaked inner cannula to remove all secretions. Rinse it in the sterile saline basin and dry with sterile gauze. Then gently slide the inner cannula back into the outer cannula and lock in place. You will not have cleaned the outer cannula at all. It is preferred that a second person be available to assist with changing the ties on the tracheostomy, only because there should be no opportunity for it to be dislodged. An obturator is kept at the head of the bed to place in the tracheostomy opening in the event the outer cannula of the tracheostomy tube comes out. As this is an emergency situation, it should be avoided by having the second person with you for the brief time it takes to change the ties. Cut 2 pieces of twill from the tracheostomy cleaning kit, about 12 to 14 inches long. Make a fold about 1 inch below the end of each piece of the tape and cut a 1/2 inch slit lengthwise in the center of the fold. Have the second person gently hold the tracheostomy tube in place with gloved fingers on both sides of the neck plate and providing reassurance and distraction to the client. Untie the old tracheostomy ties. If they are difficult, be careful if cutting them, as you do not want to cut through the cuff inflation tubing. Use tweezers to pull at them until they come loose from the neck plate. Insert the split end of the tracheostomy tape through the opening on one side of the tracheostomy tube neck plate. Pull the distal end of the tracheostomy tie through the cut end and pull tightly. Do this on the other side as well, while the second person continues to stabilize the neck plate. Then tie the tracheostomy tapes with a double knot at the side of the neck to avoid any pressure source at the back of the neck. These tapes need to be snug enough to hold the tracheostomy tube in place while allowing one finger beneath the tape for neck movement. The second person can leave now and wash hands. There is a split gauze in the cleaning kit that will slide under the neck plate of the tube to provide a cushion for the skin and absorb secretions. Discard all used materials and wash your hands. As with all procedures, document the client's response to the treatment and that the treatment was completed. This procedure becomes more comfortable for the client the longer the tracheostomy tube is in place. As long as the client is made to feel secure and secretions are frequently removed, the tracheostomy cleaning procedure should feel safe for the client. Ideally, every client's environment should be restraint-free, and it is every nurse's goal to make it as restraint-free as possible. However, clients who are at risk for injury, whether from falls, wandering, diagnostic or therapeutic procedures, or behavioral alterations, must be protected, and there is a variety of ways to keep them safe. Restraints are protective techniques or devices used to limit a client's physical activity, either because that activity might be unsafe for the client or for others, or to immobilize a body part. Physical restraints are attached to the client's body in some way, while chemical restraints are medications used to limit or control behavior. Alternatives to restraints are techniques or devices designed to either minimize disruptive behavior, distract the client from risky behavior, or monitor the client's actions in some way. Restraints restrict individual freedom, thus their use is limited to situations where the client poses a danger to self and others, or when a body part must be immobilized for a procedure. Any use of restraints for behavioral management without the provider's order is considered false imprisonment and is illegal. Regulatory agencies such as the United States Centers for Medicaid and Medicare Services and the Joint Commission on Accreditation of Healthcare Organizations have established standards for the safe and appropriate use of restraints. These standards make it clear that the reasons for the use of restraints must be documented clearly, and all less restrictive interventions must be implemented first. Safety measures the nurse must try first include checking on the client frequently, putting the bed in the lowest position, using diversion or distraction, or moving the client to a more supervised area, for example, closer to the nurse's station. Many other alternatives are being used to keep clients safe, such as replacing full side rails with half rails to keep clients from climbing over them toward the foot of the bed and falling, placing a personal item on the door of a wandering client's room to help her identify it, and using environmental restraints, such as furniture or large plants as barriers, to deter wandering clients from venturing beyond appropriate areas, provided, of course, that this does not create a fire safety hazard. Another idea that many institutions use is the concept of sitters, family members, trained volunteers, or healthcare workers who accompany clients who need continuous supervision to stay safe. A variety of products and devices have been designed for client safety without physical restraints. One example is a lightweight electronic alarm that can be positioned on a client's leg. An alarm will sound when the client begins to stand, kneel, or crawl, alerting the nursing staff that the client might be at risk for falling. Another is a bed monitor, a mat that is attached to the mattress under the sheets and will sound an alarm at the bedside and at the nurse's station when the client attempts to get out of bed. Similar devices are also available for wheelchairs and toilet seats. Another option is a soft-sided self-enclosed bed that has a vinyl top and a zippered nylon net canopy to keep the client safely inside without restricting movement. Yet another option is a low bed, a bed that keeps the client only inches from the floor, yet can be raised to the appropriate height for delivering client care. After other methods of keeping a client safe have been attempted unsuccessfully, or in an emergency situation when a client becomes combative, the nurse may have to apply physical restraints to protect the client or others. The nurse must then obtain an order from the provider to continue the restraints. Examples of physical restraints are a vest restraint, a sleeveless jacket with straps that cross the chest and pass through slits in the vest so that they can be tied to the bed frame or to the legs of a chair. A belt or strap restraint, applied over the client's gown or clothes, around the client's waist, then tied to the back of the chair or to the sides of a stretcher. A mitt, mitten, or hand restraint, a closed, thumbless covering that goes over the hand and is secured around the wrist. This type of restraint keeps the client from scratching, picking, or removing therapy devices without unnecessarily restricting limb movement. A wrist or ankle restraint, a padded strap that wraps around the wrist or ankle and is tied to the frame of the bed or chair to restrict movement of that particular limb. The nursing care plan for restraining a client must be specific and must include all legal requirements and an outline for safety and documentation. Safety measures for clients in restraints include removing or replacing the restraint frequently, padding bony prominences under or near the restraint, performing neurological and circulatory evaluations of color, sensation, temperature, mobility, and capillary refill of the area distal to the restraint at least every 2 hours, allowing enough slack on the straps of the restraint to enable the client to move both arms and both legs to do range of motion exercises, using knots that are easily released and do not tighten when force is applied, such as a clove hitch or a half bow knot, keeping the restraint loose enough for the nurse to fit 2 fingers between the device and the client, never tying straps to the bedside rails. An upper body restraint must be tied to a portion of the bed that moves with the client when the bed position is altered, explaining the need for restraints to the client and family, evaluating the continued need for the restraints on a regular